Great. Thanks very much, Dr. Cleve. It's just the two kids, or when I left the house this morning, it very much still was two. So I hope that's the case
Oh, well, yeah.
when I get home. But anyway, thank you. So yeah, thanks very much. My my talk today is about local staging for prostate cancer, and principally how to predict extraprostatic extension, and how we can use this to improve patient counselling in the clinic, but ultimately improve patient outcomes, satisfaction, principally in regard with surgical margins and biochemical recurrence. So my aim's really to provide a bit of a whistle-stop tour of the past, present, and some future insights into predicting extraprostatic extension. And I'm going to go through quite a few topics, principally with a focus on MRI scanning and PSMA PET, as I think these are really important, relevant areas. On the face of it, it might seem like quite a niche topic, but we all deal with prostate cancer staging and diagnostics, in general practice in the clinic. So I think if it's not interesting, I think some of the general takeaways will hopefully be applicable to everyone. So starting with what is EPE, or extraprostatic extension. So put simply, this is prostate cancer cells outside the prostate. Now, it's particularly difficult with the prostate to assess this, because there's a lack of formal capsule within the prostate, and this is particularly important around the apex. Also, sometimes there are fat cells within the prostate, so that makes reading these slides difficult for the pathologists. The concept of what constitutes EPE was first introduced in 1993 by Epstein and his group, and he suggested a cutoff of 0.5 millimeters at radical prostatectomy was a reasonable cutoff. There's no nationally or internationally accepted definitions of what constitutes microscopic or non-focal or extensive EPE. So I suppose for the purpose of the talk, the definition is prostate cancer cells outside the prostate. Now I may refer to extraprostatic extension, or EPE, or extracapsular extension, or ECE, or T3A, but essentially I mean that local cancer spread. And you can see this depicted in these H&E slides. So there's focal on the left and non-focal on the right. The dotted line represents the prostatic capsule, and then the black arrows basically just point to the cancer cells outside the prostate. So why is it important, and why did I choose this topic? Well, put simply, EPE is predictive of both biochemical recurrence and ultimately patient death from prostate cancer. So adequate local staging is essential for us as surgeons to plan an oncologically safe operation, but also for the patient to be fully informed about the risks of nerve sparing when counselling them in the clinic. Now, regarding nerve sparing, both North American and European guidelines state that nerve sparing should be offered for localized prostate cancer, but the concept of what is localized is well, I would say relatively poorly defined. Also, within the guidelines, there's limited guidance on how to assess EPE, or how results should inform nerve-sparing strategy. And I think particularly in the system in Canada that we work in, there's a huge variability on pre-biopsy or pre-biopsy or pre-prostatectomy imaging, and also the biopsy method is pretty heterogeneous, which does make counselling these patients in clinic challenging. So what do the guidelines say? Well, this is just a passage listed from the AUA Astro guidelines. And they say that clinical T stage should be principally ascertained by DRE. There is a bit of a nod towards MRI, and they say that findings may provide additional information regarding local tumour extent and may be utilised in disease prognostication and treatment planning. This is just lifted from the EU guidelines, and it's pretty similar. So again, clinical T staging should rely on DRE findings. However, MRI can still be useful for treatment planning. And they reference the low sensitivity of MRI for focal microscopic EPE, and I'll talk a lot about that later. So before kind of embarking on the talk, I just kind of did a mini audit of the last 50 prostatectomies at VGH, and this was really from November, December to January. These are both open robotic, and just to highlight, these are patients referred in from external centres as well. It was difficult to capture who's having a DRE, but I'd imagine this is near 100%. I'd think it'd be difficult to envisage a situation where you have your prostate removed without having had a rectal examination at some point on your pathway. I would say I generally do a DRE if patients haven't had an MRI in the clinic, or if they haven't had an MRI prior to having their prostate out. So once they're under anaesthesia, as I think it helps inform that nerve spare strategy. Interestingly, 34 out of the 50 patients I looked at, or 68%, had a preoperative MRI. And I included PSMA PET just for interest, as I'll come on to say, what role this may have in the future. But just 2 out of the 50, or 4%, had a PSMA PET, and these have been private payers. So this is an outline of a few of the key aspects that I'll address, and I'll try and move through things chronologically. Now, I like that a lot of these talks start with a bit of history, so this is my effort to emulate this. I was delighted to read that it was a British surgeon that is credited with the first pathological description of prostate cancer back in 1853, and this was actually a whole 14 years before the Canadian Constitution Act. But that's the last or little I know about the Canadian Constitution Act. So for over the first 100 years of its existence as an entity, DRE and histopathology formed the basis for diagnostics. And I suppose of relevance to the talk, the first nerve spare prostatectomy was described in 1982. Around that time, there'd been early attempts with CT and ultrasound imaging to image the prostate. PSA was first approved by the FDA in 1986 for disease monitoring, and then 7 years later for screening. In the 1990s, there's emergence of nomograms to predict outcomes, including EPE, and then development of MRI principally in the early 2000s, with PSMA PET emerging in the 2010s. And then obviously there's the future things that I'll go on to talk about. This is a bit of an outline of the things I'll talk about, and we'll start now. So for the first section, I'm just going to talk about, inverted commas, past techniques to include DRE and nomograms. I put the past in inverted commas because, obviously looking at the guidelines, DRE still forms a key part of clinical staging. So what is the role of DRE in today's practice for local staging? Well, as I said, it's formed the basis for over the first 100 years of existence. PSA didn't come along to the 1980s, and systematic biopsy wasn't introduced until around the same time. And as I say, according to the guidelines, it should play a big role in today's local staging. But as I'll try and highlight over the next couple of slides, I think we need to and can do better than simple DRE local staging. Also, it's difficult to find modern studies looking solely at DRE as an isolated predictor, because a lot of the modern studies, are about amalgamating DRE with other parameters. So a logical first question to ask would be, does DRE correlate to prostatectomy specimens? And this paper, published in the journal Urology, looked at assessing DRE correlation with final pathological outcomes, including EPE. And just tried to pick out a couple of headlines. So of those patients with EPE on radical prostatectomy specimen, 36% had EPE at a site that was listed benign by DRE. And furthermore, 31% of patients that had a positive surgical margin had that positive surgical margin at a benign site. So as detected by DRE, over a third had EPE at a benign site, and just under a third had a positive surgical margin at a benign site. Now, this is just a nice summary table sort of lifted from that paper. And if you sort of look over the Spiegelman series, as that was a particularly low number, if patients had a palpable abnormality, then the range of those with tumour confined to that same side of the palpable abnormality was only 11 to 27%. So this study kind of implies that DRE wasn't really good for locating tumour within the prostate or predicting EPE or positive surgical margin. So this is a more modern paper that evaluated over 90,000 patients that underwent a DRE and they were logged in the American National Cancer Database. And they looked at DRE with what they determined as advanced pathological features. Now, these included positive margin and T stage, and it also included nodal status, which is obviously less relevant to the talk. So as you might expect, The advanced clinical stages, so T3 and T4 as assessed by DRE, although a relatively rarer finding in their paper, were associated with higher pathological stage, nodal positivity, and also positive margin. To me, what perhaps is more interesting is that palpable versus non-palpable, so T1 versus T2, and that's effect on outcome. Because I think it's those patients with non-palpable or just about palpable disease that you may be able to help with some of the other things that we'll talk about today. So if you had clinical T2 disease as assessed by DRE, this was only slightly more likely to result in pathological T3 or greater disease than clinically non-palpable disease. And if you had clinical T2, and these two patients were only slightly more likely to have a positive surgical margin than those with non-palpable disease. So this would suggest that DRE may continue to provide some information and insights into more advanced disease. However, its utility in detecting local extent of prostate cancer for the majority of patients is more minor. So I suppose just to summarise, I think based on these couple of papers presented, DRE is not a particularly accurate tool in defining the extent or location of prostate cancer within the prostate gland, and the correlation of DRE with extracapsular extension or positive margins is pretty poor. And I think it's hard to justify surgical approach based on DRE alone. So next I'm going to talk about predictor models and nomograms. These were generally developed to try and predict outcomes, including organ-confined disease, from a mixture of clinical and pathological variables. So the first nomogram developed was by Alan Partin in 1993, and he's pictured here. There have been several modifications over time, but principally the Partin tables rely on pre-treatment PSA, Gleason score, and clinical stages dictated by DRE, and they predicts outcomes, including EPE. Interestingly, it doesn't offer side-specific risk, and I think that's really important for its utility in forming surgical decision-making, because if it doesn't give a side-specific risk to what is a side-specific operation, I think it's much less applicable. The next nomogram developed really was the CATAN or MSKCC nomogram, which is pretty similar to Partin's. It does give some slightly different outcomes in terms of primary treatment outcomes, and does rely on, I suppose, a bit more pathological details, so primary and secondary biopsy score, and also number of negative and positive cores. But again, it does predict extracapsular extension. Again, doesn't offer a site-specific readout. So there's absolutely loads of studies and external validity studies looking at these, and I tried to summarize the evidence into this slightly wordy slide, but generally speaking, these nomograms have very good internal validity, with their end of the curve and greater than 0.8. This doesn't really play out across the real world, and sort of this large meta-analysis by Zhu et al. Showed a more moderate performance. And also the largest external validity study by Rocca et al. They incorporated over 6,000 patients, included validation of the Partin's table, which performed particularly poorly. Generally speaking, the kind of readout from the literature is that these nomograms tend to over-predict EPE. As I said before, they're not size-specific. So if we're talking about planning nerve spare and planning an oncologically safe operation, it doesn't really give a guide as to extent or size-specific surgery. And I suppose in summary, I do wonder whether or how clinically applicable these are to the everyday clinician in practice. It's not something I've used day-to-day routinely, and I'd be interested in if other people do use these nomograms routinely. So the next things I'm going to talk about are kind of early or current imaging techniques, to include the things listed here. And as I said, I will focus mostly on MRI scanning, because I think that's probably the area of most relevance. So to start with ultrasound, the first ultrasound examination of the prostate was published in the 1960s, But as you might expect, the imaging quality was pretty poor. The 3.5 megahertz transrectal probe, which we use today, was first done in the 1970s, and obviously that presented new opportunities for imaging. On truss, signs of extracapsular extension are focal bulges, irregularity of the capsule, or echopore stranding of the periprostatic fat. Now, I chose this image because I think even I can see the big white arrow pointing to cancer, which is apparently tracking down the seminal vesicle. Now, as for the accuracy, again, I tried to sort of amalgamate papers here. The sensitivity for truss at predicting EP is between 50 and 92%, and the specificity between 46 and 91%. The trend of this was definitely towards the lower end of this range, although it is a bit better for T3 disease, which is shown here. There were various attempts over the years to try and improve the accuracy of this with things like color Doppler, but obviously prostate cancer isn't particularly angiogenic, and obviously when it's small and localized, this only leads to moderate improvement in sensitivity. So next on to CT scanning. Now, I'm sure everyone has read the CT report that says focal abnormality within the prostate gland, consult urology. But on this image, you can see that focal abnormality with the white arrow. So you can see that area of enhancement with pointed out with the arrow. Generally speaking, CT is not good for soft tissue characterization, and because of this poor ability of CT to differentiate between the soft tissues, the sensitivity is very low, as you'd expect. And again, papers that I read were sort of less than 30% sensitivity for T3A disease. As with ultrasound, is a bit better for T3B disease, but still probably less than 60% sensitive. So on to MRI scanning. Well, MRI imaging of prostate was first done in the 1980s using a 0.04 Tesla MRI. Now, things in accuracy have obviously moved on a lot since then, and we're now using 1.5 or 3 Tesla machines. So just to give a flavour of what we're looking for on MRI, this is a pretty nice example, an obvious example. Now, I can't do any pimping on Zoom, so I'll just describe it. But the image A is T2, image B is diffusion-weighted imaging, image C is ADC, or apparent diffusion coefficient, and image D is dynamic contrast enhancement. Now, these images represent the large PIRADS 5 lesion in the right anterior transition zone. And as you can see in the images, it's very low T2 signal, high DWI, low ADC, and then increased early enhancement compared to the background prostate. And you can see the arrow in image A. Now, this points to an area of expected extracapsular extension because there's significant bulging of the lesion into the periprostatic fat. And also there's a large degree of capsular abutment, so 50 millimeters of capsular abutment with loss of that capsular contour. So the key features to assess EP on MRI based on the PIRADS score are listed here. So capsular abutment, irregularity, spiculation or retraction, tumor capsular contact greater than 10 millimeters, neurovascular bundle asymmetry or thickening, bulge or loss of the capsule, extracapsular disease, and obliteration of the rectoprostatic angle. Now, I'm not saying we should all be radiologists, but I think if you're doing these operations, it's important to be able to read the basics. And I think having looked through the papers and those factors which are important, I think the degree of capsular contact is probably the key subtle feature that as a sort of surgeon, and not being a radiologist, you can look at. And I think that's particularly important when you incorporate that with other factors that we can interpret, so the pathology, PSA density, or the PIRADS score. And those are all variables that we can easily interpret and help to predict extraprostatic extension. And then using those MRI images, we can then hopefully inform surgical margin or surgical approach. Now, this paper from Cambridge in the UK actually shows that point quite nicely. So they basically found that if you had grade group 3 disease and above, and capsular contact of greater than 5 millimeters, the positive predictive value of having EPE was 90.9%. And if you had less than grade group 3 disease, if you had capsular contact of greater than 12.5 millimeters, there was a positive predictive value of 90.4%. So I think analysing our own MRI can help influence, or should it help influence surgical planning? So I suppose then the next question is, does it influence surgical decision making? And this is quite a nice paper from an Italian group showing the influence of MRI on surgical decision making. So they had around 150 patients at a couple of high volume centres who had a preliminary plan based on clinical data, and then the surgeons were given MRI information, and they also had a control group of a similar number. The nerve-sparing plan was changed in almost 50% of individuals, and interestingly, it was changed equally in terms of a more radical and less radical approach. Furthermore, they had significantly lower positive surgical margins in the MRI group. So, this would suggest that MRI influenced surgical decision making for better patient outcomes. So this is a similar, this shows similar outcome. So, a 2019 study of over 1,000 patients undergoing radical prostatectomy. Those that had an MRI had much more increased chance of a nerve-sparing approach with a risk ratio of 1.84. And also this group found significantly improved positive surgical margins with their MRI group. So that's, case closed, all good then. MRI influences surgical treatment planning for the better. Well, on that, there are definitely some studies which don't play out that improvement in positive surgical margins. And the problem with MRIs isn't that sensitive as a standalone predictor of EPE, and I'll develop that on the next slide. But I just wanted to share this last paper on this topic, which was published in European Urology, where basically they randomized 400 men to either an MRI or no MRI. And their positive margins didn't reach statistical significance. So it's 23% compared to 19%. Part of the reason for including this, though, was that I think they hypothesized there was definitely a benefit with clinically impalpable disease. As I said before, I think that's interesting because I think these are the patients that you have room to help potentially with utility of MRI. The other thing about this paper is that they did find that the index tumor, as identified by MRI, was the source of the positive surgical margin in almost 90% of cases. So to me, that, with the very high positive predictive value of MRI, may just be that better surgical planning was needed. But perhaps that's my MRI bias. So I alluded to this slide on just a second ago, but just to develop the idea that the MRI doesn't have a standalone good sensitivity for predicting EPE, and particularly microscopic EPE. And this is a meta-analysis, again published in European Urology. It's quite a busy slide, but I just wanted to show the tables to show the range of sensitivity and specificity. And the pooled sensitivity and specificity were 0.57 and 0.91 for the detection of EPE with prostate MRI. So I suppose the conclusion being that MRI alone isn't enough to predict EPE accurately. So is it better than DRE? Well, I think the short answer is yes. This group looked at over 1,500 cases and risk classified them and staged them according to both DRE and MRI. And in the comparative analysis, MRI was more sensitive. One thing to mention, and the reason I include this paper, is it was interesting that 29% of MRI patients were upstaged. So I think there's a significant risk of over-treatment with MRI if the sensitivity is low, but a lot of these patients are being upstaged. So to sort of summarize MRI, I think MRI definitely has the potential to detect EPE, which has sort of shown to have implications for surgical planning and patient outcomes. I think the previous slides have shown a high specificity, but more moderate sensitivity. And particularly with the heterogeneity and how these are reported and quality of images, I think the results should be interpreted with caution. As I've shown here, that there are various MRI criteria for evaluating EPE, and and how MRI can be utilised is, I suppose, is still to be determined. One area of interest is how MRI can then be incorporated into nomograms or scoring systems. And I really like this one from Sotrick et al. I think you could really easily use this in the clinic. And furthermore, it gives a site-specific risk of EPE. There are a couple of other models I read about, but one uses a pretty complex scoring system with data that wouldn't always be available, and the other had pretty poor external validity. But you can see this model from Sotrick is based upon PSA density, MRI, whether there's an MRI lesion, and what the ISUP biopsy grade was. And based on their EV model, there's very good external validity of 0.83. Now, in their paper, they apply a 20% risk threshold cutoff as the point at which they would recommend nerve spare. So within their cohort, 58% of these prostate lobes would be appropriate for nerve spare and fall below that cutoff. And of that group, only 9% would have EPE. So I think you can say this is a pretty realistic cutoff and a pretty good EPE outcome. But ultimately, that balancing decision is for the patient. So I suppose I really like this. I really like this model, and I think you could definitely use it in the clinic. I think ultimately the controversy within the literature exists on what threshold you apply, what level you say or adopt a more conservative or less conservative approach. But I suppose ultimately that's a decision for the patient. So the last topic in this section is micro ultrasound. Now, I really like micro ultrasound, and it's something you have here that we don't have in our centre back home. For those who don't know, micro ultrasound is a high resolution ultrasound-based imaging modality that operates at a higher frequency than conventional ultrasound system. Now, studies have shown comparability with MRI for detecting significant prostate cancer. The extent to which micro ultrasound can detect EP has been assessed in a small number of studies, with similar results really to MRI in terms of sensitivity and slightly lower specificity. The key features are similar to that of MRI, and this image highlights some of them nicely. So this shows a large Primus 5 lesion, as evidenced by the green or outlined by the green arrows. There's an area of capsular contact identified by the orange arrows, and then loss of the prostatic seminal vesicle angle identified by the blue arrows. So I think micro ultrasound is a really nice adjunct that you guys have here. I don't know whether Dr. Gleave or Dr. Manus look at this when doing their biopsy, but it does have an emerging evidence base, I would suggest, particularly in the patients that don't have an MRI. So now I'm going to talk a bit about future techniques and other interesting things. Again, I'll focus mostly on PSMA PET, as I think this is probably the most relevant area at the moment. So it was difficult to find any good data about the proportion of patients that have PSMA PET imaging as part of primary staging in Canada, but I'd say anecdotally it's low single-digit percentage of private payers. Again, anecdotally speaking, it's I think slightly higher in the UK for primary staging, but it's taken off in a relatively big way in Australia as a result of the pro-PSMA trial. I think it is coming into the guidelines, and as a result, I think it will become more standard of care, particularly in the light of this trial, which showed that it's more accurate than conventional imaging, so CT and bone scan for systemic disease. I think this hasn't translated into survival outcome yet, which is principally why it's not on the guidelines, and also raises the question of what to do with false positives and things. Anyway, I'm rambling slightly about its role in systematic disease, but I think it does have a role in local staging. So these images are a guy in his 70s with prostate cancer. Image B, you can see avidity within both lobes of the prostate. Image C shows involvement in the seminal vesicles, and interestingly, image D shows prostate cancer tracking up the left vas deferens. So, is PSMA PET better than MRI for local staging? Well, this is quite a nice paper from Alberta that included 150 patients who had an MRI and PSMA PET within 2 weeks of each other prior to radical prostatectomy. And they found that PSMA PET was better for extracapsular extension detection, and also for detection of the dominant nodule, as well as tumor laterality. I'd say in this paper that MRI does perform reasonably well here. So as I've said with previous topics, there is or was is a real heterogeneity within the literature. There's a real difficulty in how these are reported. Even within the studies, there's variability between hospitals. And this is a nice, albeit retrospective study that looked at added value of PSMA PET. And contrary to what I said on the last slide, MRI was more accurate here. Both obviously, well, not obviously, but both were more accurate than DRE at identifying EPE. But the reason I included this slide was the potential added value of using MRI and PSMA PET. Combining the modalities improved sensitivity and improved negative predictive value for both EPE and seminal vesicle invasion. So I think in summary from this paper, could the two modalities be combined to guide treatment selection? And that's the reason I like this, because I would suggest it's likely in the future that MRI and PSMA PET are combined. So is this the future of staging? Well, I think it's a future I can envisage. PSMA PET is becoming increasingly more common, particularly in Australia. In my experience, it's increasingly done, in the UK. And certainly all patients in the UK would have an MRI pre-biopsy. So I can envisage this becoming a standard of care in the future. Now, that being said, there are conflicting results. As I mentioned, there's real difficulty in how these are reported, even into hospital variability. Another interesting aspect specifically of PET imaging is what tracer is used. Now, 18-fluorine PSMA 107 is not excreted in the urine, so you'd hope that tracer would provide better local regional staging because it doesn't accumulate in the bladder, affecting image quality. Although that being said, in the last paper I showed you, they did use this tracer and it didn't, they compared the tracers and it didn't show much difference. So I think ultimately this is rapidly evolving space. It needs a large-scale randomized data to try and answer some of these fundamental questions. So next thing I'll talk about SAPIRA. So this is a site-specific extraprostatic extension risk assessment tool, which is basically a model that leverages AI modeling to help predict EPE. And this figure is just taken from their external validity study, which incorporates over 2,000 patients. And this graph just shows the predictive value. So you can see, the dark blue dotted line. I'm not sure how well it predicts, but the dark blue dotted line is the SAPIRA model. And nicely, for the purpose of the talk, actually, they've included a Soteric MRI in purple. And you can see that their SAPIRA model performs favorably, compared with the conventional models. The two things on this, I think obviously you need real-world data to see if this can improve patient outcomes, but also there's no sort of simple plug and play option for this as far as I'm aware. So there's no online tool that you can just put patient information into. But I suspect that will be developed. So the next topic I wanted to talk about, is it makes sense that if you can't predict accurately staging preoperatively, can you do an intraoperative assessment? Now, this technique called NeuroSafe technique was developed in 2012, and it's basically a standardized procedure that uses intraoperative frozen section analysis of the prostatic resection margin to try and maximize neurovascular bundle sparing. So hopefully it aids the surgeon in balancing nerve sparing and positive surgical margins. Now it's used in the UK principally in a private setting, as it's fairly well marketed, but I think it's more commonplace in Europe, particularly in Germany and the Netherlands, I believe. It does rely on the whole prostate being removed intraoperatively and then sectioned accordingly. And there is a trial that's recruiting in the UK called the NeuroSafe Proof trial, for which this schematic is lifted from. And whilst this trial is still recruiting, the process has been reviewed in this review published by Kroon et al. which looked at over 7,000 cases across 14 studies. Now, generally speaking, the evidence is weak, but it did show that in cumulative analysis, more patients underwent nerve-sparing procedures with fewer positive surgical margins. And interestingly, all studies that showed a control group did show higher potency rates with the NeuroSafe cohort. But there are obvious downsides, to this. The time taken, I think, it ranged from 35 minutes to up to 70 minutes, I believe. You have the associated loss of neuroperitoneum, associated blood loss, potential for sweating for the fellow or resident trying to re-establish the neuroperitoneum, and also, the cost or the fact you need a dedicated pathologist to section this. It'd be interesting to see what the trial shows, but it's an interesting area for development. As I say, if you can't predict it preoperatively, can you predict it intraoperatively? So on to kind of intraoperative imaging. Now, this is a figure taken from just a phase 2 trial published in the Lancet Oncology last year. So OTL-78 is a PSMA-targeted near-infrared imaging agent that's essentially injected into the patient, and then using the TAR probes on the XI, you can see areas of fluorescence, and also you can image them on the back table as in image A. I should have said, image B is the intraoperative images, and then also C and D are macroscopic and microscopic sections of fluorescence. So this was just a phase 2 trial of 19 patients. 3 out of the 12 with intraoperative fluorescence had an additional resection, and there were no adverse effects of the installation of the chemical. So I suppose whilst it's only a phase 2 trial, it does show feasibility of intraoperative imaging to enhance margin detection rate. And again, this is a sort of exciting area for development. Now, that leads on nicely to sort of my last topic for discussion. So simulated Raman histology is one of Dr. Manis's research interests, and I'm sure people will have seen this machine rolling around the office. So stimulated Raman histology is a novel real-time imaging technique that provides histological images of fresh, unprocessed and unstained tissue within minutes. These images are displayed on a screen and can be interpreted either by humans or AI. Now, several AI Raman convolutional neural networks have been developed and tested and compared with histopathological specimen. The SRH images are of 3 by 3 or 5 by 5 millimeter tissue. Pseudocoloring is applied to kind of mimic the appearance of H&E, and the scan time is around 5 minutes. So the question is, can this be leveraged to help answer some of the questions posed today? So this is a figure taken from an article hot off the press, published just before Christmas in the Journal of Urology, looking at whether Raman can detect intraoperative margin. So this figure represents a participant who underwent a Raman intraoperative assessment. And you can see the photo on the left is the intraoperative photograph showing the prostate resection bed and 2 areas of interest, which are marked A and B. For each marked area, there's then a corresponding Raman image labeled A and B with the AI overlay labeled A1 and B1. Now, A1, you can see has lots of red in it, so that's indicative of grey group 2 cancer that infiltrated the margin. And area B doesn't show any reds. This is benign area. Now, in this cohort, 32% of patients had a positive margin, and intraoperative Raman assessment of these correctly identified a further 43% of these participants, enabling a further resection. The participants that experienced a positive surgical margin that was not detected by these Raman sampling had a positive margin at both had a positive margin at either distal apex or the bladder neck. So the scan time in this cohort between 4 and 7 minutes, compared with the NeuroSafe technique, this has real potential to improve intraoperative outcome without compromising surgical time or things like blood loss. So this is a figure of unpublished data. Now, it examines whether Raman and AI can help predict EP in prostate cancer biopsies. So you can see the receiver operating characteristics curve in panel A shows a high degree of accuracy with an area under the curve of 0.9 for EP prediction in prostate biopsies. The Raman images and corresponding AI attention overlays for prediction are shown there. Now, it doesn't display that well on the small screen, but in panel B, there are two images, 1A and 2A, which show the Raman images of two different patient biopsies. Patient 1 has EPE and patient 2 doesn't have EPE. 1B and 2B then show the AI overlay for cancer detection, and 1C and 2C show the overlay for EPE prediction. And then panel C is just zoomed in Raman images with overlays for the same cases. This just shows how the model uses benign stroma to predict the EP status. Panel D just shows the top 10 predictive patches for EPE, and these are highlighted in red. And then panel E is just zoomed images. So this is an exciting unpublished data which does show that in the future Raman could be leveraged to help inform EP on prostate biopsy. So just to summarize the future, I suppose, PSMA PET has utility, I think, for local staging, and this is potentially enhanced in combination with MRI and potentially even the future of general staging. I think AI can and should be leveraged to aid any algorithmic method. And I think real-time pathology or interruptive frozen section has real future potential to overcome some of the difficulties with preoperative staging. So I suppose the question is, what have I learned having done this, done this talk, and what would be my takeaways? Well, I think, look, DRE still has utility, but I think the accuracy is principally in that higher risk category staging, so sort of T3 and above in terms of its sensitivity. I think when I'm looking at MRI scans, I'm really going to take into account the degree of capsular contact and also combine that with the things I can interpret, so PIRAD or report I can read, so PIRAD's pathological outcomes and PSA density. I really like that Soteric nomogram that I showed you. I think this is a well-validated but critically easy to use site-specific tool that you can use to help counsel the patients. I suppose finally I'm going to try and source some micro-ultrasound for biopsies in the UK. So to conclude, I think currently the current best practice lacks accurate diagnostic sensitivity, and I think that's why the guidelines are phrased in the way they are, and they reflect that lack of accuracy. I think current best practice is still a combination of DRE, MRI, with or without a nomogram, like the Soteric nomogram, to help inform patient decision making. I think PSMA PET has a real potential to improve things in the short to medium term. And I think a combination of AI and real-time biopsy or frozen section have potential to improve things probably in the medium or longer term. So thanks to Dr. Manus for sharing his really interesting data, and I welcome any questions or comments.